afternoon, everyone. I'm going to call the meeting, the Committee of the Whole, to order. Sheila, can you do a roll call for us?
Yep. Mr. Furman? Dr. Giles, she gave notice she wouldn't be able to attend. Pastor Jones? Present. Dr. Guadalupe? Ms. Woodruff?
Here.
Dr. Hans? Ms. Newman? Ms. Root? Here. Ms. May? Mr. Smith? Here. Mr. Cowan? Mr. Young?
Here. Okay. First opportunity for public comment. Can we check, is there anyone online?
If you are online and wish to speak for public comment, please raise your hand at this time. Joy, you can go ahead and unmute your mic.
Thank you. I wish I was there in person to give public comment, but couldn't make it today. My name is Joy Wilkins. I have a brother and sister with intellectual and developmental disabilities. They have self-directed their supports and services in Troy for over 20 years. I'm here to speak on their behalf and for other families who are too afraid to speak up about the difficulties they're experiencing here in Oakland County. OCHN leadership has become disconnected from the individuals they are responsible for serving and safeguarding. We feel ignored. Some of us have been present since the implementation of self-determination in Oakland County, and we lived it. What doesn't work is the managed care culture that the current administration has now at OCHN. Managed care and self-determination are contrasting philosophies. OCHN is not an insurance company. It's not intended to act like one. OCHN's focus is no longer on the people and service, but distracted by its quest to earn the next state contract. OCHN is responsible for managing public funds for people it serves, but the people are no longer a priority. I hear OCHN representatives say, the system is underfunded. And although that may be true, we need to figure out how we meet people's individual needs with what we have. And it just hurts to hear when OCHN staff and administration can receive better quality insurance plans, but some of our service providers and caregivers are not being paid, or their wages are being arbitrarily reduced. OCHN's answer is standardized rates. And now, because of the threat to lower rates at the end of this year, my family is at risk of losing the best care providers we've had over the last 4 years. The agency will be forced to accept the standard rate, a rate less than they have been paid for the last 4 years, or quit altogether. The answer from OCHN is that we just need to find a new home care provider. A new home care provider who is willing to accept the standard rate. Easier said than done. It's difficult relying on the public health system for health and safety of my family members, and the struggles are real. I kindly ask the board to consider putting people and their challenges back into your conversations. Otherwise, how are you helping our community? Find a way to engage with individuals receiving supports. We are showing up here today to tell you that we want to be heard. Thank you.
Any other comments from online? Your opportunity, anyone in the room? Movement. Can we move to item C, approval, a motion for approval of the agenda? So moved. Motion and a second, all in favor by aye. Aye. Any opposed?
Aye.
Policy management's up first today. Okay.
Alan Bolter.
Good afternoon, everybody. Good to see everybody again. My name is Alan Bolter. I work for the CMH Association of Michigan. Just wanted to give the board, the committee, a few updates on what's going on, particularly regarding the PIHP procurement process, and then if you have any other questions, policy-related questions of what's going on in Lansing regarding budget or other items, happy to take questions from the board. As far as the PIHP procurement and kind of where we are in the process, I think the committee is well aware that the submission date was October 13th for submissions that were due. We have been involved in litigation on this issue with the state. We did have a hearing that took place on October 9th that was in the Court of Claims in front of Judge Christopher Yates. Judge Yates did offer 2 opinions, now did not render a final decision, but did issue 2 opinions that came out on October 14th. So in the judge's opinions, he basically said, 1, that the state can competitively procure these contracts. 2, the state does have the right to reduce the number of PIHP regions. However, in his second opinion, he did say, while the state does have that authority, their authority is not unlimited, and they do not have the ability to amend or change state law through this RFP process. And we have our next hearing in court is going to be December 8th. And that hearing is going to really focus around the legality of the RFP. Is, in fact, the state changing the law through this RFP? And really specifically, they're going to look at, in the RFP, it talks about that the new entities within the 3 regions, they shall not delegate any managed care functions to provider entities, so to the CMHs in those particular regions. Well, as you're well aware, in the mental health code, there are a number of sections that outline you as a CMH, what you are required to do, and a number of those would be managing networks, doing compliance, contracting, oversight. All of these things are managed care functions. So what the court was saying in his second opinion was that the department does not have the authority to take a role and responsibility that is outlined in Michigan law in the mental health code and give it to another entity through this RFP process. So as they continue to go through the legal process, that's really what the next hearing is going to be focused on. Now, the state will come in and argue that they're not doing that. They have the ability to do that. I mean, our side will obviously argue that they are, in fact, violating and changing the mental health code by making those changes. Again, we'll see what that looks like. The legal process is kind of more of a start and stop. It's a hurry up. You get to court, go through the hearing, and then now they're stopped until the next hearing. We're in the process now of going through depositions and kind of putting together the legal arguments that'll go in front of the court on December 8th. And the reason why the hearing will take place on the 8th, we have heard that the department intends to make decisions on the submissions or to award contracts sometime in mid-December, and we've heard the date of December 10th. So Judge Yates wanted to have a hearing to make his final decision on this prior to the department issuing any awards. Now, I believe if the department moved and decided to make awards prior to the December 8th hearing, the judge would in fact issue a a restraining order, an injunction, and stop the RFP process altogether, knowing that's kind of the situation that we are in. Again, we will see what happens. I think, part of the issue and part of our complaint and, what I've talked to the legislature about this, our issue with this RFP process has really been, the process and the timing in which they are trying to rapidly move this through prior to the administration departing next year. And again, these contracts that they are putting before here in this RFP process would go into effect October 1 of 2026. And again, that is roughly 30 days for the next election for the next governor of the state of Michigan. So in fact, they'll be having contracts that'll go in place. The people that are making these decisions now will no longer be in that position after the end of next year. We'll have an entirely new gubernatorial administration that'll come in. They are simply tying the hands of the next administration. This has been done very much behind closed doors. It has not been open, has not been transparent. Again, this is not our first rodeo at this type of a process of looking at bidding out, changing the managed care structure and the behavioral health system here in Michigan. The previous two iterations of this, roughly 3 years ago with Senator Mike Shirkey, actually had legislation. So that went through the legislative process. Outcome was very similar, but far more transparent, far more open than what this process has been. And then prior to that was Governor Snyder with Section 298, and that was actually boilerplate that was in the DCH budget at the time, the Department of Community Health budget at the time. Again, far more open, far more transparent. Actually, Governor Snyder, as you may recall, had then Lieutenant Governor Brian Calley head up a 100-plus person work group that took months and months to look at this issue. So again, far more open, far more transparent on that. I guess that's probably about what we know on the PIHP front at this time. A lot will be told, obviously, with the hearing that takes place now on December 8th. And then what happens from there is a whole lot of speculation of if this does get, if the department is ruled against where their RFP is illegal, can they pull that RFP back? Can they rewrite it and resubmit it? What does that process look like? Again, the timeline is very tight as far as trying to get something done, and it's a whole lot of guessing, and things get very muddy very quickly once and if the judge rules against the RFP and really what that process looks like moving forward. So I know there's a whole lot of talk and speculation out there, but again, we'll kind of have to wait another 28 days or so to see what that looks like between now and then. I guess happy to, if the board or the committee has questions about that, happy to take questions on the RFP process itself. I don't know if there's any questions that folks may have, but that's kind of where we stand today.
Mr. Smith.
Thanks, Alan, and thanks for making the trek here from Grand Rapids, and nice to meet you. One thing that people have been asking me is, okay, this RFP process is, it keeps coming back to the table, and there's a lot of discussion, and honestly, I don't see the same groundswell of support from providers and individuals that I saw from a distance on 298. And I know personally, I've seen community mental health other CMHs like Washtenaw County and the Wasco case and the Wiesner case, and Livingston County, the Bacchus case, which were, in my field, cases in which the Disability Rights of Michigan really had to stand up for our beneficiaries when their due process rights were really being undermined, and millions of dollars were spent by CMHs to contest our beneficiaries in what I personally view as curtailing their due process rights. I know you can't control all your members, but I watched the Court of Claims hearing, and I look at your PowerPoint here, where our members support change and improving the system. Everything I've seen so far is defensive, and it's kind of the 298 playbook. What messages are we sending out there proactively for those who are desiring change, what we're going to do?
Yep. No, I mean, that's a good question. I mean, and this is very different than the past, iterations of this. I don't think there's as much unity on our side as there has been, and I know there's a number of folks in the provider community that certainly support change, and that's something that we're going to continue to work with them on some of their concerns. I do think a number of the concerns could be addressed, but it does not. And our biggest issue is going through this RFP process. If we want to change the system, the number one thing, when I talk to lots of legislative offices, all the calls they get are access to care, their workforce-based issues, crisis-based type services, inpatient access, things of that nature. Those are the biggest kind of sticking points in the system. This does nothing to change any of those. So, I mean, that's one of the biggest questions that we've been asking over and over again is, well, why are we doing this? I mean, what are we actually going to improve? My argument has been, we're simply changing one set of problems for another set of problems with this proposal. So we're not actually fixing any of the real issues that are out there, the difficulties that people have, accessing and receiving services. So, I mean, I think it's something that, we have talked to, different provider groups. We've reached out to Kevin Fisher at NAMI, Sherry Boyd at the ARC, have sat down with them, kind of listened to some of their concerns. I mean, we would very much support if the department wanted to pull back the RFP, that they actually pull together some kind of a stakeholder group, bring in all the key stakeholders. And one of the things that we're critical of is the department has basically picked and chosen who they wanted to listen to as they developed this RFP. But if they brought in all the key stakeholders and said, clearly, here are the issues, here's what we want to address, here's what we want to get to, sit down and let's work on that and move it forward. As you saw in my PowerPoint, I've got a whole bunch of members, and we represent all 46 CMHs, all 10 PHPs, 100-plus providers, a whole bunch of them that certainly support change, but they have to be at the table. Dana has to be at the table. Our members have to be at the table in order to work on this, to address the issues and move something forward. Otherwise, we think that individuals receiving the services will be certainly harmed in that. They have not been. We through the association have had one meeting with the director on this since February. We have not been working on this, and I guess that's our ask of them is pull this back. Let's convene a group of all the key stakeholders, bring in the providers, bring in the advocates, bring in our members, figure out where we want to go, and let's sit down and do that. The last time we went from 18 PHPs down to 10, I mean, we literally had, that was in 2014, literally had the department come to our office and say, 18 is too many, we want to make these changes, and literally sat down with us and worked with our members back and forth, and landed on the current 10 structure that we have now, for better or for worse. That's something that could be done. Again, this RFP process was manufactured, created by the department. That doesn't have to be there, and I don't think it serves the end result, which is trying to put together a system that best serves the people. But I mean, to your original point, I don't think all of the collective support is with us on this effort. I think there's a lot of frustration out there, and something that, we think that could be fixed and settled if we were all able to sit around a table and work on it.
And I think, just to be clear, I'm against the RFP process. I think Judge Yates said it well when he says, maybe legal, but it's unwise.
Yep.
I think, and I totally agree with that. At the same time, I think we all can agree on these 4 strategic pillars, that their changes, I don't know, I shouldn't assume we should all agree, but they seem pretty obvious as things we could agree to improve the system. And I would just like to see us, both as OCHN and also as a larger CMHA organization, address those 4 pillars head on and say, hey, this is what we think we can do, and not just say, if we come to the table, like, let's proactively put together a document saying, these are the things we're going to do to address those 4 pillars. And I think that would be very effective, Alan, in getting more support. And thank you again for coming today.
Yeah, no problem. Now I would say, and I've said this a ton, their 4 pillars, I think, are somewhat ironic. I think their proposal actually contradicts almost every single one of those of their pillars, where it talks about improved access to care. Yes, we all agree on that. They talk about that they want to improve choice. What they fully mean is, when they look at choice, we're going from 10 regions down to 3 regions. They fully intend to award multiple payers, multiple entities per each of those regions. So when they talk about choice, they're talking about choice of payer. We believe that individuals care a whole heck of a lot more about choice of provider, who's providing their care, than actually who's paying the bills, as long as the bills get paid on time and they're not screwed up. They also talk about administrative simplification and reducing bureaucracy. If you're going to have multiple payers per each of those regions, every payer you add, it takes money away from services. They're all going to have their own IT systems. They're all going to have their own compliance, overhead. That all adds administrative costs, bureaucracy, confusion, difficulty for people getting services. So, I think that their pillars that they outlined, I think, are wise. I think their plan contradicts many of the pillars that they've outlined.
Anyone else? If there are no further questions, we thank you, Mr. Balter.
No problem. Thank you.
Turning it back over to you, Mr. Young.
Thank you. So we'll move on to item 3, the Finance Committee. First up is financial update. Richard, can you give us the update on financials for September and walk us through the details?
Good afternoon. All right, we have preliminary September financials available for you tonight. Again, the big disclaimer when we talk about September is the end of our fiscal year. However, we do take time to make sure the books are fully closed. There are final grant reports that are due, some in October, some in not until November. There are claims run out, which we give our providers anywhere from 45 to 60 days on claims sometimes, which means that for September dates of service, there may be claims that we haven't even received yet. They wouldn't be here until the end of November. So all of that to say, yes, September is the end of the year, but these are preliminary September numbers. As we walk through the highlights, on this first slide, we have revenue. The revenue continues to trend slightly above the 2024 amounts. Just a quick note that we did start receiving revised payment rates. So the state of Michigan, as had been talked about probably earlier in the fiscal year, they did look at the number of eligibles that we were receiving, and this is a statewide trend, and they did go back and they did revise the rates. When they revised those rates, they did increase the revenue to be received. What they did, though, is instead of in the past where we would see a spike in a specific payment month, they did do what's called a recoup and a repay. So all of those revenue bars that you're now seeing on the trend, all of them have moved up a little bit with that recoup and repay. Next slide, please. On the eligible side, again, we are still seeing that eligibles, which is the bar chart, is slightly below the 2024, which is the red line trend that we had from last year. It is also below the 2020 trend line, which we show in blue, which is the pre-pandemic. So we are below, or we're approximately at pre-pandemic levels for eligibility. Next slide, please. A couple of comparative charts. So we do have our asset comparative chart for September. We do see that the switch to fee for service has had a positive impact on our cash flow. So cash at the end of September, cash and investments, I should say, at the end of September is up compared to a year prior by about $30 million. And part of that is that some of our receivables are down as well from the year prior. So that was receivables we had from primarily related to receivables from the state of Michigan for some of our CCBHC that they owed us for fiscal year 2024. Next slide, please. On the liability side, vendor payables is also up, and again, that reflects the fact that as you move to a fee-for-service arrangement versus the prepaid service models, is that there is a little bit of a delay from when we get the claims submitted to OCHN, and then the processing time, and then the cash goes out the door. So that explains the increase in the payables. Next slide, please. The net position is then just kind of the difference between our assets and liabilities. So again, assets are up, a lot of that being in cash and investments. Liabilities are also up. The net impact is that we expect net position to be down about $2.2 million at the end of or we're projecting that now at the end of September. So at this point, we're projecting a use of about $2.2 million of fund balance related to the fiscal year end. Again, preliminary numbers, so that actual use of fund balance could be a little higher or a little lower than that as those final settlements are taken care of. We get the final claims in and paid. Next slide, please. Now we have comparatives for revenue. So again, from fiscal year 2024 to fiscal year 2025, we are showing a revenue increase of about $33 million. And again, that is going to be both the revenue adjustment that we saw in the rates as well as some additional changes in the PPS1 rates that we see are passed through to us related to the CCBHC program. Next slide, please. And then on the expense side, we're seeing an increase on the provider expenses from 2024 of about $2 million. So again, an increase year over year, but not quite as much of an increase as the revenue, which results in again, much closer to break even in 2025, at least projected compared to 2024, although again, still utilizing reserves to supplement that revenue to pay our expenses. Next slide, please. And then that brings us to our comparative for the net income. So again, total revenue up compared to 2024, total expenses up slightly compared to 2024. The loss or the net income, is significantly better from a $24 million loss in 2024 to projected $2 million loss in 2025. The next couple of slides are related to, the next slide is related to our top 12 providers. So it gives us a little bit of a trend on who are we paying the most money to. So those are our top 12. And then the following slide is a description of what each of those 12 providers do for us within the network, whether that could be fiscal intermediary services or other services that they provide. The next slide's related to the monthly finance report. I take the same information we just walked through, but give it in a little bit more granular detail. So I'm happy to try to walk through those. Or
let's take a pause, see if there's
questions
on this, and then we'll dive even deeper. So first, from Finance Committee, any questions? Wow. Policy Committee, anybody? Yes.
I do have one question. So with the CCBHC being a direct pay this fiscal year, how much of a reduction is that in the actual budget?
A lot. We're estimating that it's going to be $50+ million reduction on both the revenue side and on the expense side. However, we do have a concern that when the state does what they call the rate setting process, that's where they look at our historical expenses, not just for us, but for all the PIHPs statewide. And then they try to estimate how much revenue they're going to have to take out of that so that they can pay the CCBHCs directly. We do have a concern, along with our PIHP counterparts throughout the state, that they may have overestimated how much revenue they're going to take. So we've gotten our first payment for fiscal year 2026. We got that about 2 weeks ago. Unfortunately, that's not enough data to do a trend yet. So our hope is that by the end of this month or the end of December, we'll have enough data to trend that out and see what the actual budgetary impact will be for 2026. So we do expect it to be a lot of money. And in theory, our expenses should go down by a similar amount if the state took out the right amount. That we're just uncertain if they took out the right amount.
Thank you.
Richard, can you just educate me on what fringes is under our expenses?
Fringes would be any kind of non-actual like payroll that goes out the door. So that could be health insurance, that could be retirement, it could be any other employee-related expense that's not the actual like salary going into the gross pay.
And just so, and I realize it differs from budget, but why are we $3 million above when we had salaries and fringes versus the previous year? We're down in the next part of the report.
Chris jumped ahead.
No, I don't. Am I in the wrong?
No. We're just, I was kind of wanted to do the macro stuff first, then dive into the weeds, but that's okay.
Gotcha.
I thought I was looking at the year-to-date at the bottom. Okay.
Yeah, so I would have to go back and do a deep dive into the specifics of what the changes were, but I do see on the income statement that the prior year total versus the current year-to-date total does look like fringes are up about 1.7.
It's okay. Do you have more, or you're good? Okay. We'll come in. So I want to kind of go back up to the eligibles in this. Nasser, Dana, maybe even Trish and Richard. So I understand why we're down from the last couple years on eligibles, but falling now below 2020. Has the county changed that much, or are people just not applying? Or that's part one of the questions, because then part two is we've talked for the last 2 years about people being in the wrong categories, or just the mishmash of when parents and families interact to try and either get onto Medicaid, or when the child turns 18 and you're still in the like a post-high program and have to deal with it. So kind of a two-part question. First, I'm surprised we're below 2020, which just seems strange in the climate we're in. And then the second is continued mismatch of, are they in the right programs?
Yeah, I'll try to address, from my perspective, both of those. So first I'll say that it's not an Oakland County specific phenomenon. So we are seeing that same trend across the state in terms of the eligibles now starting to drop below the 2020. And unfortunately, some of this is speculative, but one of the things I will say is that with the increase of the minimum wage that happened recently, and the upward pressure that has on salaries in general, and the increase in the federal poverty level has not been increased at the same percentage as the minimum wage in the state of Michigan, that could have an impact where people who may have been just below the eligibility threshold would now be above. And that would be a change from 2020 to 2025. So that would be one example of a reason why someone might not be eligible that otherwise would have been, even if nothing else changed in the community. So that would be one example. In terms of the eligibility category mishmash, I think we are still seeing and still discussing with the state. I mean, there's been no change from my perspective that we believe there are people that are falling off of DAB during the re-enrollment process and maybe coming back in either as a Healthy Michigan or as a TANF individual, right, which we get paid significantly less for those categories than we do a individual that's a DAB, which, I'm sorry, for the committee members, that's disabled, aged, or blind, so that their eligibility is based on a disability typically or similar. And so we do believe that's still happening. However, the state continues to not engage on that particular issue. So we have had no update from the state on that. The last that I had heard is that they're saying, well, it'll fix itself, because when we go to reset the rates in the future, then we'll just increase the rate for one category or decrease the rate for another category, and it'll work itself out. The concern, of course, that we have is that we have to pay for the expenses today, not 2 years from now, and it has a negative impact on us financially now. So those would be my two. I obviously would open it up to any other thoughts about those two questions.
Go ahead, Dan.
I also think that part of it could be the return of Medicaid spend downs, which, is always a struggle for the provider perspective as well as ours in terms of what we cover with our general fund really should be covered under Medicaid, because once a person meets their spend down, if it's properly tracked, then they're eligible for full Medicaid coverage. And that has been a challenge for years. And I think with that returning, you're seeing that impact as well.
Okay. All right. Thank you. Oh, Chris, go ahead. Yeah.
John, it's a follow-up to your question. And I do think the state is screwing up on DACs left and right still. And so I hope we're flagging that and addressing that. But one thing that John's question brought up is we're becoming very dependent on Healthy Michigan. I mean, it's becoming more and more. Shouldn't we be proactively now looking at, can we get people off of Healthy Michigan, because it's easy to apply for, it's easy to get on, particularly when we're looking at, big beautiful bill implementation. What does us an organization can do to make sure these people on Healthy Michigan couldn't apply for other categories that might be long-term more sustainable for us?
I'll speak from kind of a high-level finance person's perspective of my understanding, but I understand that it is an operational question to some extent, and it's also a partnership question of how do we engage with like the local DHS offices that are helping people to apply and so on and so forth. I will say from a strictly finance perspective, while Healthy Michigan is on the eligible side, as we see on the slide, it's a significant portion of the eligibles that we're seeing. And just to be clear, on the slide up right now, that's the blue category. So it's the blue at the top there. If we were to go back one slide to the revenue, and I apologize that the colors don't match up, but on this slide, the revenue, Healthy Michigan is the purple. So you'll see that the purple on this slide is significantly less from a revenue perspective. And that's in part because our expenses for Healthy Michigan as a proportion of our total expenses is significantly less. So yes, we're becoming more reliant on Healthy Michigan. And yes, if it were to just go away, it's not good for our community. It's not good for the individuals we serve. From a strictly financial perspective, there are things that we would have to do to right size if Healthy Michigan went away. So that's as much from a finance perspective that I want to address that. But if there's operational discussion or community partnership discussions on how we can encourage eligibility into those other categories, I'll let someone else try to address that.
We are working very closely with our DHS workers that are here and present in our office as well as out in the community to make sure that when people have challenges or they're in the wrong categories or they're on a spend down or they're in other programs, to check their eligibility and make sure they're in the right category, the right type of Medicaid coverage. Our concern is the unknown, of course, and whether Healthy Michigan and those other subsidies are going to be available after the new year. So again, making sure that people are in the right categories, and when they fall off, we really have to stress upon our providers as well as ourselves, and Richard and I had a few ideas today about how we make sure that people are doing an ability to pay. And by doing that, you can determine if they're eligible for something that they're not getting, but also what is their portion of payment. And that's always hard when you're dealing with a group of people that we are supporting, having them to do an ability to pay and understanding how you could ask them for anything in terms of a deductible or copay, when they're looking at such a small coverage package.
This, the idea of ineligibilities and what have you, and I don't know if that's the track I want to go on. I guess what I want to try to understand, and it may not be understandable, may not even be a solution, but we're constantly hearing that our direct service providers, that their pay is not right, okay? And I'm not sure what category that would fall under. In relation to that, the care of a person, is probably the most important thing to the person whose son or daughter is in need. And the idea of that provider that's supposed to be taking care of that kid, that they're not getting what they should. And now you're struggling trying to figure out where to send them. We just had somebody say something to that. I don't know in the numbers. Is that in there? Is there something else to look at, whether it's Healthy Michigan or whatever, that we could look at? If it doesn't fall under the eligibilities, and maybe that's not where it should be, but the question has to be, is there a level? And maybe there's never going to be a level, okay? You know, all of a sudden maybe, hey, this is where it's going to be. You're always going to be short on that. But I guess our challenge, and I don't know what's in the numbers or not, is how do you try to somehow or another equalize the service with the pay? And so, you know, I mean, we're looking at things. My partner over here talks about this great big bill and all of that, which we know will have some impact, more negative than positive. But for that person, that mom, that dad, that's sitting there looking at their son, or that brother or that sister that's looking at their relative, saying, how can I do this? How can I do it? So I don't know if it's in the numbers or not, and it may not be. And maybe that's a challenge of all of us, okay? Maybe it's a challenge of all of us. How do we match it? How do we match it, you know, with the services that the groups that's out there that's offering these services that are partners with us? We have some great partners and all of that, and we're doing a great job. But at the end of the day, the question is, that person that I'm depending on to watch over my son or my daughter, my brother or my sister, they may not be there tomorrow because I'm not paying them enough. Now, if you ask me what keeps me up at night, I'm going to tell you that's one of them. And it probably keeps all of us up. And I know that's not your problem, okay? I mean, you know, you're the guy that works with the numbers, but is there something that we're missing? Because that question is brought to us each time.
So the reason I raised it is because 2 years after the pandemic ended, we are still wrestling with people who were disabled in 2022, go into your world for a minute, miraculously no longer are disabled, right? So they're not getting the right reimbursement.
Where do they go?
Well, but it's the paperwork, and I know the callers in always say none of us know what we're talking about, but I live this every day. And going through those processes, one, you got to be paying attention that you actually get the email. And I follow electronically quite a bit, but I'm not sure everybody does. You don't get that email, you are told you failed to comply, and you get kicked out of the system. So some of this is right back to Lansing of how do you, when the politicians talk about compassion, and this is the email, I no longer have food stamps. You know, we can watch the news and that, but I've seen it. And I've actually experienced it where I was sitting with my phone while I got an email that said, you failed to show up to your appointment. Now, I can pull a lot of levers and got back to the person and said, look, here's all the electronic tracking. You failed to call, but your bureaucracy sent a message that said, we failed to show up. So that's part of it. But that's why I raise it, because if you're in the wrong category, your rates are going to be lower. We can talk about it at a macro level, but yeah, it affects everybody in the field. So that's why, and it's frustrating because 2 years out, this is still an issue. So,
Mr. Young, and the other thing is, most people, and if we didn't work in this, don't know if they're a DAB or a TANF
Right.
or
right.
any of that. They just know that they want to go see a certain doctor or a certain person that helps them. They have no clue who their payer is. And for us sitting here, we can pull up an email and get an email, and we can follow up on it. People don't have Wi-Fi. They don't have access to emails. And so there's a lot of barriers for the most vulnerable people to have to
Right.
try to figure this out and navigate and advocate for themselves.
Yep.
And even trying to get through an application, one of the ones, the application, a short form, is for a TANF, right? A temporary aid to needy families. The longest piece of this application is for somebody who's disabled, aged, and blind. So that's what happens too, and that's why it's so critical that we do work with the DHS workers to help people overcome the barriers for them accessing the resources and the help. And even through all of that, it's like you said, we still get an email that says we're no longer getting
You know,
SNAP.
Yeah.
So,
Yeah.
yeah.
Yep. All right. So that was the high level stuff. Sorry, Rich. Now we go into the details.
Yeah, so at a high level, again, the details are going to just be literally the details of what we talked about. I would like to briefly address the increase in the salaries and fringes. I would have to do a deeper dive into specifics, but off the top of my head, one of the things that I would say is, as we continue to get more grants that are funding co-responders or other staff, right? Because of how we have historically categorized the financial statements, all salaries and fringes have fell under the general administration category. So there's not a separate grants specifically for salaries and fringes. I think most of the grants expenses are for pass-through subrecipients. I'd have to verify that. So I think that could be part of the answer, is grant-funded expenses, including salaries and fringe benefits for staff, could have an impact of why we're seeing an increase, because I know we're expanding on some of those grant positions. So.
And I would just add to Richard, as we continue to bring in-house services and provide more and more direct services, that will have an impact on that as well.
Yep. The plan for 2026 is we will start to separate out from general administration. We would have a separate salary and fringe line for direct service provision, because that's going to become part of our book of business. So that'll be more clear on the financial statements. And then we could also break that out for grant expenses as well. So we could have a level of granularity that might help with that. But I did not have any other specific highlights from the detailed pages of the financial statements, unless there are questions that I can try to research for the committee.
I think it would be a good idea to break out into those three categories.
Okay.
Because I think grants is important, but to understand both the inflow and the outflow makes some sense. All right, questions from Finance Committee? Policy Committee? Chris?
It looks like this was budgeted, so I just probably not educated, but seeing it at the end of the year helps. It looks like there was an $8 million decrease in community inpatient and an $8 million increase in mental health and IDD services there. That just because those are large numbers, what are those connected or just coincidental?
We're on page 15.
14. Yeah. Oh, wait.
So, yeah, so we had the increase on the mental health and IDD services of $8 million and the community inpatient reduction. I don't know that I wouldn't necessarily say that they are specifically related. It could be related to the inpatient would be related to authorizations and how many off. Of course, as we're looking at intending to try to cut back on our spending, we would try to be very intentional on continuing stay reviews and follow-ups. So that reduction may not have anything to do with the increase on the other line. I would expect that the increase on the other line could have a few different causes behind it. The CCBHC falls into the mental health side of that service line, and so it could be partially an increase related to CCBHC that would fall into that. I could get more granular, and I could bring that back for the committee if you'd like. Yep.
Okay, other questions? If not, Sheila, let's have for the board, we'll do receive and file, but maybe like a quick update to hit some of these highlights, Richard, for next week. Yeah, go ahead.
So if, just so I'm reading this right, so for the year on the statement, we got net position is 2.2 million negative. Is that the operative number?
Projected, and again, all my disclaimers about final year-end stuff, but yes, right. 2.2.
So, yeah. But just my thought is, we've sat here the past 2 or 3 years with some much bigger numbers than that.
Yeah.
So I think I was very pleased. That's almost break even. Perhaps with what's to come in the settlements and other things, we'll be able to, get that number even closer to actual break even. But maybe for the board meeting, if you could remind us what those negative numbers were for maybe the last 3 years, because they were significantly more than this. Just, check the...
I do have those numbers.
Okay.
If you would be interested in them now.
Sure, yeah.
But yeah, in 2022, we utilized $10.8 million of fund balance.
Right.
In 2023, we utilized $10.9 million, and in 2024, we utilized $24.2 million. And so, yes.
Thank you. So I just, for those of us who have lived through the last 4 years here, with all the different challenges that we've had, the one thing that we asked Dana and the team to do was we need to get stabilized from a cash flow perspective. And, this is at a $532 million that went through here. $2 million off is pretty good from my vantage point, especially with what has occurred. So a lot of the things that we've talked about as an organization, and trying to stretch the dollars as much as we can to serve as many as possible, I'm pleased the numbers are finally validating some of the things that we've done, especially in the past year. And of course, with you're coming on board and helping us with some of those things also. But we've got with the claims department and all the other things that you put into effect, I think we're finally starting to see some of the bear some of the fruit from those efforts. So
I have no question. Not so much another question, but I think our chair, I think I raised that early on, at an earlier meeting, in relation to where we were 2 years ago, 3 years ago, and where we are today. And, I'm excited about where we are because it certainly shows the effort that this board, every member of this board, has had to deal with and work with, and I'll call it success in relation to where we are, of the input and support of each board member and our leadership team, our CEO and our chair. So that's one thing, and I appreciate what he's saying because I think that should be noted. It should be noted from where we were to where we are today. That's one. Number two, at an audit, I know they give comments, suggestions, blah, blah, blah. We ask a lot of questions. And my partner down at the other end of the table, I'm thinking of moving him up here with me. is there a way that in some of the questions or some of the answers that we could note it, and that way, we know we answered it, or there's something else we need to further follow up on, or what have you? Maybe it's a footnote, not so much that it's, the audit report, like for the list things, what you could do and all that other stuff. But I think, some of the questions are just really exciting to us. And there's probably some follow-up that we can do or should do, which would be pretty good. Because I may forget by the time I get in my car and go home. And so if I come back and I see it in writing, it may help me. I don't know if that's possible or not. Maybe more work for you, but, you've given some great answers and all of that. But I think like the questions have been asked have been so good for us to know. Good for us to know. And as we move forward with what we have to do and what we have to deal with and what may be forthcoming, to say, okay, here's what we said, here's what we're putting in place, and it's working. Because that's about 2 more hours of your work.
So in terms of like putting a note down, like in terms of like the verbal conversation we had today with the questions and the answers, to have that in writing to refer back to?
Yeah.
Is that the question?
Maybe I'm the only one who,
I can, so the questions for Richard that comes back are noted, and that for him to respond, that if he couldn't clarify it tonight.
Okay, thank you.
Is that what you're asking? Because you're asked about the audit process as well.
No, well, not the audit.
Okay.
I know what happens in an audit. They talk about what you did, what you didn't do, and what you'll do, blah blah blah. I'm telling you, when we're going through something here today, unless I write it down and say, my partner down at the other end said this, and this is what we got, and I got an answer. But 2 days from now I may forget. But the other part of that is some of what you're telling us today, which is really good, and some of the questions have been asked is very good. Unless I'm writing them, or maybe that's something Sheila writes in her notes or something, but from your note to say, this is some of what we're thinking, and here's one bullet. And I'm not asking for a narrative. I'm just thinking a bullet,
That would be the meeting minutes.
Yeah, so I do have that as a follow-up.
Yep, okay, all right. And then, Richard, you do a little, I was just going to say, good point. Maybe rather than just a simple receive and file, we'll do like a little overview for the board meeting. I think there's a lot was covered, and it'd be worthwhile to do that, whether you're in person or virtual, but
okay.
I think. And
I always need something to read at night.
Well, Sheila, there you go. You can add more to the meeting.
And Pastor Jones, we always need more work.
There you go. Okay, all right. All right.
He told you to expect that. He told you. He said, hey,
there you go.
Pastor's going to be asking questions. All right.
Always full of questions. Okay, all right. Richard, thank you. I think we're,
thank you.
I think we covered this thoroughly. Next, item 4 is other business, crisis transition update. Kim.
Mr. Young, even before or after Kim presents and Kalia, I think it's Kalia, yeah, Kalia's coming up, present, I would like to have a few comments as well. I could do it before. So I know the last month or so has been quite challenging in terms of getting the communication out to the community and having meetings with the Board of Commissioners, as well as internally talking about our strategic plan and our annual plan. And within those plans, you will see that we talk about our crisis continuum and how we're going to expand on our crisis continuum. We made a point of not speaking negatively about our vendors or any of our vendors or providers, because we do appreciate and respect the work that they're doing. But when I first got here over 5 years ago, one of the really major goals that I promised this board, and there were different people on the board at the time, Dr. Guadalupe and Dr. Hans were with us, but at that time was to really look at our access points, expand access, and enhance our crisis continuum. So we have crisis services throughout our community, and making sure that at any point, anywhere someone goes, they have an ability to be in contact with services. So in doing that, we wanted to align with SAMHSA and make sure that we're doing programs and services related to crisis that are aligned with SAMHSA and their model of providing the coordinated system of crisis care. So we are looking at how we align with that, and part of it is the component of having somewhere to call, somewhere to go, and a safe place for help. The other one has to do with person-centered care. The other one also has to do with accessibility. And we know at the location of the Resource and Crisis Center, we have our New Oakland for our youth as well as Common Ground for our adults. But we also see an opportunity to improve upon our crisis services. And we've been working on that over the last few years. And I'll say what you see are the outcomes of that work with our co-responders that we now have 10 of, and we're looking to expand across the county, with our CIT, and we just got, and I was hoping somebody made this big announcement, the Platinum certification for CIT, Crisis Intervention Team Training, which is huge. And then really working with the Citizens Advisory Group and the Recipient Rights Advisory Group and our law enforcement partners, looking at ways that we can expand access and improve our crisis response. So we know that there are 4 services that we are looking at, and those 4 services have to do with crisis intervention, which is typically through a mobile crisis team, crisis stabilization at the units at Common Ground in New Oakland, crisis phone calls, and also this does not impact 988 whatsoever, and mobile crisis. And mobile crisis is a section where we really, really struggle, but we also have this huge partnership with our law enforcement community and peers and things of that nature to help fill in those gaps. So as we move forward, really this is a part of our strategic plan and our transitional plan to make sure as we evolve that we're using this opportunity to improve on those crisis services, because we know there is much room for improvement, and it is not to displace anybody or displace a service or a vendor, but we are, as CMHSP, responsible for the oversight and provision of crisis services, and we're going to use that opportunity to do that. So I'll let Kim and Kalia present the information.
Okay, thank you.
Mm-hmm.
Good evening. My name is Kimberly Flowers, the Chief Clinical Officer here at OCHN, and with me I have...
I'm Kalia Anstead. I serve as the Director of Crisis Services here at OCHN.
Kalia has been here a little less than a year, and she has made herself very known and very important in this whole project here. She's got a big job, and we'll support her, but I'm glad to have her here with us. If you would continue on, please. So we're here to talk a little bit about our intention to transition crisis services. And I'm going to read a little of this because some of it I want you to know. The Crisis Continuum provides a coordinated network of behavioral health crisis services designed to meet the needs of residents across all stages of a behavioral health crisis. Our goal, to ensure timely, passionate, effective support that promotes recovery and reduces the need for higher levels of care. So we want to be able to support those that are in crisis. Dana spoke to the SAMHSA model of someone to talk to, some place to go, and all of those pieces there. And so we want to be able to do that, to do just those things, and then also to reduce that inpatient level of care. We want to catch it if we can, work through the crisis, and then divert. Thank you. Next slide, please. So the purpose of the transition. Why do we want to do it now? Everybody's asking, why now? What's going on? Well, we've listed a few reasons here. I'm going to expound on them a little bit as I go. So for better coordination across the crisis services. Dana mentioned that she talks about our CIT, and we have various access points for crisis, and whether it's our community, whether it's our sheriffs that do drop off, whether we find crisis in the schools with liaisons, whether people are calling from the hospitals, all of the areas. We want to better coordinate that care, that first access point, from the point that there is identified that there's a need through the delivery of the service and also through the diversion, if we can, back into the community with supports or for a contact with our hospital or our other areas, our crisis residential, our partial programs, or wherever there needs to be support and proper handoff. Next, faster response times and streamlining of referrals. So referrals, again, come from a lot of areas, right? They don't just walk in the door and I'm in crisis. You could get a crisis from now our walk-in center. We could receive a crisis from our mobile team that can't handle it in the field and need some support. We may get a CIT, or it could come from anywhere in the community. And we want to be able to faster respond, right? We want to be able to understand what's coming through our door. We want to be able to identify what the needs are, and then we want to be able to get it to the right place as quickly as possible. The request comes in. You don't want it to have to filter through different areas. You want it to be very streamlined and that we have our hands on what the crisis is and what the needs are. Enhanced follow-up and post-crisis care. I did speak to that earlier. Enhanced follow-up and crisis care. Whenever you're providing crisis care, or if there's someone been in the hospital, or however that is, there's a need for follow-up. Follow-up is very important. First of all, you are, in that point, giving a lot of attention to a crisis, a lot of time, a lot of resource, a lot of energy to support the people in crisis. You don't want to leave them with nothing. They have to have somewhere to follow up. They have to have somewhere to anchor to support, and to continue on, and then to create some post-crisis additional services that might need to be needed. And so we want to enhance that follow-up, understanding that the people that we put in place have the ability to do that and have a facility able to do that, and we're able to do it on time, right? We're able to know that it happened. We're able to document that it happened, because sometimes those pieces are missing. So we want to be able to do that and have that strong follow-up in our own services and in our own hands. Stronger accountability and oversight. Well, I mean, if we're going to do it, we're already accountable. But if we're doing it and we're in it, our hands and feet are in it, I hate to say something that folks say, they say 10 toes down. But anyhow, we're in it. We are in it. Our hands are in it. Our feet are in it. Our minds are in it consistently. Our compliance officers are in it. There's auditing in it. There's improvement plans in it. There's a lot of things that go in it, and we are accountable for that oversight. So we can not only work with those who deliver the service directly, but we can also plan and provide further education and more insight into why this is happening, if it's not happening appropriately, but also cheer when it does happen appropriately and good care, and we have good outcomes. We can keep all that data ourselves. A unified experience for individuals in crisis. Every person receives the care that they need, whatever that care is. It's identified by person, by family, by need. And we want to be able to have individuals who are trained, that we train, that provide that service, that care, and that individual care as people come in and are working through their crisis. And then, of course, most importantly, well, I don't want to say most importantly, but definitely importantly, aligning with the state crisis delivery system. There's a model of care out there, and we want to ensure that we're providing that care, identifying and improving upon that care, monitoring outcomes of that care, and again, finding opportunity and gaps if we're not providing that care. Now, that took a little time, but I want you to understand that we do want to hold that direct service. We do want to provide it. We want to ensure it. We want to be accountable to it. We want to oversight it. We want to provide outcomes, and we want to see that what we're doing is working. And if it's not, we want to immediately know that and put some things in place to do that. Next slide, please. Transition timeline. I'm going to go through this last slide, I think, and then I'm going to hand it over to Kalia. transition to OCHN management phase. So we have a phased approach to what we're doing. Many people want to know, what are you going to do first, what dates, what timelines, and this kind of thing. What we did here was we provided you a little bit of timeline, a broad stroke, but timeline's just the same, so you can see what our intentions are in our phased approach. So winter 26, we intend to transition the front of the house, which includes our operations, our front desk, lobby, crisis assessment services, along with our sober supports unit, at the Resource and Crisis Center, the RCC. Spring of 26, we would like to transition our mobile crisis services, focused on community-based response and diverting individuals from emergency departments. In the summer of 26, we'd like to transition our crisis helpline and stabilization services, completion, of the service transfers to OCHN management. So by the end of September 26th, we'd like to have all of these things in place and under the direct operation of OCHN. Kalia, if you would move on. Next slide, please.
Yes, so we have a full spectrum of crisis support services that follow with MDHH guidelines and SAMHSA guidelines and standards. First is our walk-in crisis assessment and facilitation. That's where individuals can walk in and receive a full assessment, a triage, and coordinated care to the next level of care if needed, or a referral and warm transfer back into the community. Mobile crisis services are community-based services that provide either in-person in the community services or telehealth services for individuals who have non-imminent situations. That is led by a psychiatrist and trained clinicians and peer professionals so that the individuals can have someone to relate to with lived experience. Next slide, please. Stabilization services, which are currently in the reconfigurement with the state of Michigan, are provided up to 72 hours. It's where someone who is not quite to the level of inpatient treatment but needs some stabilization services with psychiatric oversight, nursing assessments, peer services, milieu specialists, behavioral health techs, and clinicians. So it looks like a wraparound care where you provide a treatment plan, you provide rounding, you provide supervision, medication management, and short, brief, solution-focused interventions. A crisis helpline, which serves as a 24/7 resource for anyone within our network and our county, can provide resources, help with de-escalation, and transfers to services if needed in person or within the community. And lastly is our crisis residential services, which is an alternative treatment to inpatient for individuals who are voluntary. They can stay up to 14 days and receive care that is intensive, intentional, and then warm facilitates individuals to the community for reintegration. Next slide. So our purpose is to make sure that our transition and assumption of service is seamless for individuals, that it is an uninterrupted transfer, that people still have access to care and receive the transition and services that they need throughout the full scope of fiscal year 26. We want to make sure that our staff have the mindset of service of excellence, that every individual that walks through the door should be treated with high quality care. We want to make sure that our process is focused on improvement. So as Kim stated, where are the gaps? How can we fill it? What is our plan to fill those? So how are we looking at our operational workflows to enhance efficiencies and effectiveness? And then lastly, we want to make sure that our stakeholders are engaged, are able to provide input, are able to work alongside us collaboratively to make sure that this is a seamless transition for individuals served. Next slide, please. So, experience and staffing. So our OCHN is a state section provider of crisis services designated by MDHHS for Oakland County. We have direct and indirect experience providing crisis services, including design and implementation of services, working in emergency departments, inpatient facilities, access points, emergency telephone services, along with network management and crisis service providers. We have a full implementation of the Crisis Now model, which aligns with SAMHSA at the RCC and throughout Oakland County. We have values with, we value our current partner, Common Ground, staff and encourage them to apply for positions within OCHN so that we have individuals who are familiar with our crisis system. We have a phased approach to make sure there's stability and a reduction of stress. We want to make sure that we are clinically responsible and conscientious of this transition, and that we have comprehensive training provided for a smooth transition. Next slide. Yeah.
All right. Filling the crisis system gaps. So right now we're partnering already with our law enforcement, and of course that will continue our early intervention and prevention programs here. Our crisis intervention stress management teams, our CISM, our co-responders, our CORE, crisis intervention training, our CIT program, and then our first responder support. So of course we're going to continue and have all of those at our disposal within our system and closely connected. Partner with our local stakeholders. We're going to be continuing our partnering. Currently, we have our hospital liaisons who already have made a great reduction, a lot of good effort there in decreasing the stays in the emergency rooms. They've gone down tremendously, almost to zero, that we have to find some other work for them to do because that was their main focus, and they've done it very well. That was one of our initial programs there. School mental health navigators, quite well also, our veterans navigators, our integrated urgent care, which we have now calling Oakland 360 Care Center with Honor Health, Oakland County Health Division, OCHD, and Oakland Livingston Human Service Agencies. So that's all part of our integrated urgent care system, and we call it Oakland 360 Care Center. And then finally, our increased access points. We have not only that integrated urgent care in Pontiac, we also have an access point in Southfield with our Oakland County Health Division, where we have someone there every day to support the needs that may come up if someone's having a general visit to the health department for whatever reason they may be there. Apparently getting a lot of referrals from that location as well. Next slide, please. Financial impact. As I'm going to read this here. So we wanted to be sure that you understood what we believe the impacts would be, and I'm sure there will be more, but first these. As we transition to OCHN's Crisis Continuum Service System model of care, some costs will be incurred for hiring and training. However, rest assured that the goal of this transition is to be low cost, budget neutral, while ensuring the stability and continuity of services. There'll be clear timelines with staff engagement and checkpoints as we go through this process. Stakeholder feedback will be important to us, and communication throughout the process of design and implementation. Transparent updates provided quarterly to the OCHN Board of Directors and stakeholders. Next slide, please. Looking ahead, building a stronger system together, which is what we really want to do. Through the crisis continuum, OCHN continues its commitment to delivering timely, compassionate, and high-quality crisis care, supporting individuals on their journey to recovery, and strengthening partnerships that foster community well-being. Next slide, please. I think that might be the last. Questions. So, now, we understand there are probably questions, so Kalia and I sit here to answer what we can for you, but we've got a whole team that work here with us. And if there's some that we can't answer, maybe they can do that. If not, we'll bring you back the response.
Yep.
Thank
Sarah,
you.
Go ahead.
Okay, just have a couple questions. So first is, currently, Common Ground has a lot of marketing out there with phone numbers and whatnot. Is that all changing, that phone numbers will change, or will that remain the same? And then I guess what's our communication pathway to community?
Our communication pathway, we're working now to talk about some of those things. To be transparent, there's a hotline, there's that community hotline that we have to discuss. We'll have to discuss that with Common Ground. It's owned by Common Ground. It's not the 988 number. It's just a general call-in number that's transferred. You get it. Okay, and then we have other telephone lines that we may get ourselves. We may have to get our own lines. I'm not certain quite how that's going to work, but we do understand that the line might change. But most of all, we understand the communication is important, right? We're slowly reaching out to other areas where we can be able to share and spread what's going on. Starts here, but it'll be branching out as we make those actual changes. I hate to give you something and then it be something different, but right now we understand that these are how the lines go. They have been Common Ground owned lines, right? If we can work something out to change that, we would. Who wants to have to change them if you don't have to? But if we need to do that, then we may need to do that. And there will have to be a very strong communication out to the community.
Okay, and then, secondly, I mean, we know they're not happy with this, and that's, I mean, I guess that's where we're at, but is there concern about the, having the timeline, I can't think of the words you used. There's one in winter, one in the phased approach. I mean, what barriers do you see with that, and do you foresee issues, I guess is where I'm going with that, with having them still having a part in it? I don't know if I'm communicating.
No, I exactly hear what you're saying. You know, I have to give a thank you to Heather Ray. On Friday, she did send a letter in which she acknowledged that working together on a transition plan that's seamless and smooth for the people we serve is really the most important piece. And I think that's the piece that we often forget, is that we're doing this because we want to improve quality care for people we serve. And so that communication plan is going to be developed with our communication team. I'm looking right at Suzanne. But also, we've already began some initial talks with NAMI, with the ARC, and so making sure NAMI especially, which is in metro region, Detroit, Wayne, Macomb, and Oakland, talking to them about what our plans are and how they're going to assist with getting the word out to the people, because often they go to those support groups or those community organizations to get direction on what to do during a crisis. So we definitely are including them in the development and design of that portion, or all of the portions actually, of what this looks like and what the community needs.
Okay, thank you. Yeah, I just know they've been in business for a long time, and when you see in the community, just posts on Facebook, social media, it's always common ground. So we want to ensure that community has correct phone numbers, or just that we have a great communication pathway. But I know we have wonderful people here that will help with that. Thank you.
Dr. Hans?
Yeah, just a follow-up to Dr. Guadalupe's comment. There has been quite a bit of noise in the community, and this is a major change from the community point of view. And people are kind of getting quite nervous because over the years, Common Ground has been the place for the community. So I just refresh my memory that sometimes these kind of transitions come as a surprise, not only to the community, but sometimes to the board as well. And it becomes very difficult to send the correct message. Now, right now, what I'm hearing is that there is a disconnect. The board nor the leadership here is listening to the community. I don't think that we don't care, but somehow the message is not sent out in a timely manner. This, to the community, this is a major change. Everybody knows Common Ground. I know Common Ground for the last 5 years, and that was my first experience when my child was 15 years old. And I was very nervous. How can they handle a adolescent or a pediatric age person in a place like that? It was very scary. I'm a physician. It was very scary for me. But once I went there, people were compassionate. They provided very good care. So I can feel the anxiety the community is feeling. So my concern is this, that these kind of changes, they are for positive. It should be communicated in a proactive way rather than coming as a surprise. So that's my one point. The second thing I want to understand is what I'm getting from your presentation, which is very well written and very comprehensive, what crisis services should look like. But and you have described some of the gaps. My question is that our compliance program and our quality assurance programs that we have, did they address some of these gaps in the past?
I think I'd need to hear when you say some of these gaps. I think you got to be very careful how you speak to things that are not happening, right? You never want to say things that are not, that just don't sound partnering. Okay, so if that's a word, but what I will say is that when we have found, when there has been some discrepancy in the process or service or anything that we found with respect to compliance and quality, yes, there has been some discussion of what we could do better, what can we manage better, even implementation of our. Actually, I came here on a concern when the children were in the hospitals too long, when in the emergency rooms. I think that was one of the things that was shared with me when I first got here. That was a concern, not really anybody's. It was a systemic problem, right? And calls were coming in, people were staying too long. So what did we have to do? We had to understand why, what was happening. And some people maybe have felt that their rights were, not taken into consideration when they were staying long lengths of time in the emergency rooms and things like that. And so we did take a look at that, and we did something about that, and we don't hear that as much anymore. So were some things addressed? Yes. Could everything be addressed? I think we work to try to do that all the time. We have a wonderful compliance department here, and quality. So yes, I think we have, and we'll continue to do that. But I think that it is far easier to address something when you are directly providing it, and you can see it clearly. There's there's not a secondary person to go through to get something done. So I hope that makes sense. I'm answering it the best I can. You have to give me probably more, exactly what you're speaking to. But if you're asking me, has our quality and our compliance departments been involved in the work with Common Ground and our work in the community providing crisis services? I would say yes. Are they involved right now getting this together? Yes, they are right now with policy, procedure, and process. And they'll continue to be. You're smiling at me. What you thinking?
No, I agree. No,
I'm sorry,
I think it is.
Oh, you're smiling because Marquita's sitting there.
I don't think it is in your domain, and I
you want me to stop talking?
Appreciate that Marquita is here to address that.
Well, then I'm going to stop talking.
Thank you, Marquita.
Somebody should have touched me. Thank you.
No, my whole point is that it should be described in a way that people who are not familiar with healthcare delivery system and all the regulations and how to navigate this and all the programs. So that is why we have Marquita here, and I think I would have liked to hear
and you still
something in this presentation from her as well. What are the gaps, and why do we need to do that?
Thank you, Dr. Hans. I just want to add on a couple of comments to what Kim has provided. We've worked with our current crisis provider for many years. We have audit processes in place. We, as Kim mentioned, when you're directly operating a service, you have access to more immediate information. So we will be, we're looking at where we need to expand our review, working on a plan for that. We have internal meetings weekly to discuss planning an entire cross-section of teams across this organization. So we're in a good position to roll out a definite strong plan.
Thank you. No, my point is not, please don't take it as a criticism or that I'm picking on you, but it is something we are all here to understand what we are doing here, why we are here. And crisis is one of the most important thing, and that people get to the right place, get the correct services, and continue to get those supports is important. But it has to be done within certain guidelines, etc. So that's why we are doing this.
I don't
So
have
thank you.
any concern when you ask me a question. I don't feel any kind of way about it. I want to give you your answer. And I'm not always apparently the one that needs to do that. So stop talking.
I think too, just to add to that, Dr. Hines, I think what you're looking for and asking for is more measurable outcomes of what we've seen in the past, and what are those areas that we have identified as opportunities to improve. I can give you narratives here, but I'd love to give you the data as well. And I think one of the things, lessons learned, we did cover this in previous strategic plans and annual plans, but we didn't deep dive into it. And now it's, behind the eight ball in a sense that we should have probably provided this type of presentation earlier on. And so now we're trying to course correct, of course, and then also make sure that one of the things I said about the presentation, be ready to answer data questions. And so we can give that data to show where we saw opportunities, and we also have stories to say, how do we do this better? And one of the things that we learned just last month in going to the CMHA Fall Conference is that customer service is really, really critical. And sometimes we hear back from people, or we've seen where there is a great opportunity to improve. And how do we put that in numbers? And I didn't want to come out and give like reports of the negative. I do want to point out that there are some real opportunities to do this better and to fill in some of those gaps. One of the gaps I'm really concerned about is our mobile crisis teams, and making sure that, I know virtual is acceptable, but I think we need to be able to go out into the community, and you don't necessarily need law enforcement, although we truly, truly love and appreciate our law enforcement partners. But there are signs when you can go out as a clinician and a peer to interact with somebody and help them through a crisis situation. And that is one of the things that I've heard across the county about having people to come out to a home or come out to a community place in the community where they can get that support.
Kimberly, nice presentation, really well done. And I will say and commend on all the awards and recognitions that we've gotten on crisis. And I do watch the social media feeds, and I think that is great. And I'll be the first to say I'm not a crisis expert, and I'm obviously the novice board member that doesn't have the history. But I got to say I'm almost nauseous here, and I just want to make sure if there's other board members feeling the same way that I'm feeling that way. That from what I can tell, we're cutting a top 5 provider, and somebody that I look at their website that we've had a history since 1979, which is just slightly younger than me. And we're doing it without board approval, and the decision's already done, and we're phasing this in winter 2026, which is a month and a half away, and I'm hearing we're talking, we have conversations, we have plans, but I'm not hearing anything definitive. And we're not using the word common ground as if it's Voldemort. Like there's a lot of innuendo here as far as things they've done or things they haven't. Well, I don't know what those are. I understand the need to protect our providers or, not talk ill of them, but, but I don't know why. And this is somebody with such great history. So again, crisis is not my area, but this just doesn't feel right. And I'll just leave it there.
I think that connects to what Dr. Hans is saying, and you can say if yes or no, Dr. Hans, but when you mentioned gaps, I think you were speaking to this presentation being well presented, but not being simplified enough for us as a board to understand exactly what all the details of the changes are, and definitely not for the public to fully understand, right? To have an answer to their question of why are we doing this? I don't know if you want to say yes or no when you mentioned gaps, Dr.
No,
Hans?
yes, I mean, I just, because the term gap is used, but that would be something that would be addressed in a robust quality assurance program. And we have experts here, and I think it should be a little more specific. And then if there are gaps, then people need to know about it. And people need to know that we as a board and the leadership here are working on it, that these gaps will always happen. There will always be. Medicine or healthcare is not a perfect science. A lot of it is art, and most of it is compassion and empathy and caring for people. Because without that, you can have the best science, best data, best equipment, but it's not going to be successful.
So you're saying specific, and then Chris is also saying he's uncomfortable. I am feeling uncomfortable because I don't think some of these points are as specific or as simplified, right? I want to feel like the next time we have public comment, in order to be on OCHN side, on Dana's side, the leadership side, I need to be able to be connected to the why. Why actually are we making this change, right? Because strengthening partnerships with law enforcement, hospitals, like those are such broad statements that it's not enough to work with, if that makes sense. And then I just have a couple of questions. So can you please tell me what are like the summary changes with our contract with Common Ground? Are we totally ending our contract with them? Are we decreasing the amount?
Are you talking specifically as relates to this transition or
Yes.
just their annual?
So for fiscal year 26.
One of the things that we had concerns about is that Common Ground just recently signed their fiscal 25 contract. And it was because they wanted to go month to month. They had some questions and concerns, and so getting them to just sign their contract among some of the things was problematic. And so when we look at that, we want to make sure that we have a reliable crisis response place for people to go and what to do. So that's a huge factor in that. And then when we offered the transition plan as well as the contract for fiscal 26, they would not sign it. And there are some things that we went back and forth with them to discuss. And again, I don't want to put the contractual piece out there. I don't think I can or should.
Okay.
But that was a challenge. And so making these decisions also to the point of where we're looking at funding and how we fund the crisis services when we're facing a potential change that would make our budget not even a tenth of what it is with CMHSP funding, and the other remainder of the Medicaid funding potentially going to a regional entity means that we have to be prepared to ensure that crisis services get continued. And if that happens, we would not have the budget to support paying a vendor to provide those crisis services that we know we delegated to this entity that we can bring back in.
So was it the MDHHS RFP process that really started this?
No, actually this started way before then in terms of looking at our crisis continuum and making sure that we had all the services that we're required to have that align with the SAMHSA standards.
Okay. If the RFP process continues, I know we have like 2 applications for it. Isn't it true that if one of those options gets approved, we cannot provide direct services?
We would be a new entity. So 2 things could happen. One, we would continue our CMHSP contract with the state, in which we already are. And then the other thing is, if we became a regional entity, it would be a brand new entity with a whole nother set of board members. So it creates another layer, which concerns me, but we would not look the same.
So would we be able to continue with this change with crisis services?
As a CMHSP, yes, we would.
Okay. Is the RCC, is that the right acronym, the RCC?
Yes, the Resource and Crisis Center.
Is that within the same building as Common Ground? I can't remember. I've never
Common
been
Ground
there.
is in that building. We hold the lease, and the
Okay.
crisis services will be continued to be provided there.
And they would also be in there, or no?
No, they would
Okay.
not. And they also have another location. I know they have an administrative building. They also provide services in Genesee County. What we know is that we provide 48% of their budget for those crisis services. And so the remainder of their business is with other contracted vendors, or contractors, I should say.
Okay, so overall, this would change their location of their 24/7 access center?
Yes.
Okay, that's a huge change.
If they decided to continue to provide those services for Oakland County. So they would, we would take those services and provide them in the same location, right? And they would take the services that we do not contract with them for, such as their victims support programs and things of that nature. They could still continue to provide.
Yeah, okay.
And they also have I believe it's a virtual urgent care, which is not also a part of what we pay them for.
OCHN serves the Medicaid population specifically, right?
Yes, and uninsured.
And Common Ground, for their current crisis services, do they serve anyone in Oakland County despite the insurance?
Yes.
Yes.
So if we think about that, to me, that's a critical piece of information, right? Because if someone with Blue Cross Blue Shield thinks, oh, I'm going to our county's crisis center at this address, it's been this address.
We would still serve them.
We would still serve them.
Yes,
Yes,
we
we
would
don't
not
turn
turn anybody away in a crisis situation, ever.
Okay. 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 And then what about county leadership? What have our conversations been with the county executive and board of commissioners around
I
this change?
actually met with, on 2 occasions, I went to a, Board of Commissioners meeting the Thursday before last, or Wednesday? Thank you. And Common Ground did a public comment at the end of the meeting around 8:30 to 9, and I also made a public comment. The following Tuesday, I went to a Public Health and Safety Committee meeting in which Common Ground had a presentation, and we were present to answer any questions commissioners may have. And then on this Thursday, 9:30 a.m., I will be presenting my quarterly report, which will include this crisis transition plan for the Board of Commissioners.
Are they seeming to understand the information of the change? Are they supportive of it? Are there concerns?
I think they still have questions. I think they are pretty much aware that they do not dictate who we contract with or manage our operations. They understand that the board is either in support or understands how this change will impact our relationship with Common Ground. And I think that's the thing, is just talking to everybody and really communicating. And like I said, I own it. We we should have done a better job of being more talkative about our plans and going to the various groups and committees. But we've heard these or gotten this information over the past few years about some of the things that we know. We've put in place things to address some of the issues, but we also know there's much room for improvement. And working with the crisis team from the county sheriff's office and some of the response and things that we've had to get involved with when they've interacted with some of the things at Common Ground really does help drive and support some of this as well.
Yeah. I know OCHN, we have done amazing at responding to different crises in the community. But I think the way our conversation during the presentation turned a little awkward tonight, right, it's to me is a reflection that we do really need to start these conversations around big changes earlier. That's my
please,
request as a board member.
don't think that we just pulled this out of a hat. We've been
know.
talking to Common Ground for at least a year and having this conversation about transition planning and things of that nature, and even just resolving some of the things that come up in contract negotiations. Have not always gone smoothly. And I've charged our team too. We're not about going in and you know, bad-mouthing our providers. We need all of our providers. This is who we support and we work with in the community. But also, our team is also already there in the RCC, working right alongside a Common Grounds team. And I look at Tradina and I look at her team. They're doing amazing things because, again, it's our job to triage, to understand if somebody's walking through that door, if they have a routine need, an urgent need, or an emergency need. That is truly our job to screen for that. And once that's happening, then we take them to the next step of what they need, addressing what they need in a timely manner.
Okay, thank you. I know I had a lot of questions,
No,
and thank
that's
you for
fine.
answering.
Absolutely. Thank you.
I just want to, from an operations standpoint, right? Some of the details do get into day-to-day operations, and so that's why you're going to see a lot of high-level overviews from that, from an operations standpoint. But also, as a reminder, this is in our strategic plan, in our annual plan, that we went over in detail at multiple meetings, at our study sessions, and approved at this board as well. I know there was a few times Francis and I presented where we did talk about the crisis transition as an annual goal as well. So I just wanted to remind you of that.
You want to say something?
I'm trying to cheer this cavalcade, so go ahead.
Okay, woo. I think what we heard tonight is a request for a heads up, okay? A heads up. And a heads up is, say, just want to give you a heads up on what may be coming, what may be happening. And I think that's important. I think I've discussed that, you know, that's so important for the board to have that heads up. Just want you to know, prepared, what have you, that a change has been made or something is happening. That's very, very important. We understand, you know, the same discussions that you all have had. You know, I've probably had calls as well. Want you to know that the number of people that they say are going to be displaced. They said, Pastor, you know, you're going to get rid of 195 people, and I calculated that out to tides. But the thought is the heads up prepares you, and then you want to know what's going on and how. This is not a great transition. We understand that, and we will be under view. I wrote down attitude. What is people's attitude? What will they be toward us? Perception, and we know what perception is like 90% of what people believe. People's feelings, and then how are we going to follow up? How are we going to follow up? And on this note, I saw, and it says, under your failing of crisis systems, first responder report, crisis intervention training. And there's a name on it. And I'm going to use the same thought that our CEO says. She said, don't throw out a name, okay? But there's a name on here that's in this crisis team that does not follow up. You know, I am a believer that if I call you, call me. I'm going to give you 24 hours to call me, right? 48 hours is the most you ought to have. I will tell you, on this list, there's a group that everybody in Pontiac knows. You can call the phone, they won't answer. They tell you got people there, they're not there. I had to go to the CEO, and the CEO said, okay, call me. They're on this list. You know, there's a group that started. I'll give the name of the group that started because they're doing a great job. E. Branner and Associates, Empowerment Group, doing the same thing, but they're more active. They're more responsive than this group. This group that's on here, I've been in Pontiac now 36 years, has been there before I came. and they don't follow up. And so that's all we need is to say, hey, they're in this, and somebody that was using common ground, and they don't get follow-up. Then all of a sudden, attitude, perception, feelings, and follow out of the way. If we don't have a person who is your backup, if I call you and you can't answer the phone, somebody else behind you ought to. That's very, very important, and that's going to be critical in the transition. So I'm giving you a heads up on that one group, and they know how I feel. So I've never, they got a heads up too. So very important, but I think our board should have heads up. And I think a lot of us probably know something about some of the groups on here, whether they follow up, whether they call you back, whether they don't, whether it takes 2 or 3 days or what have you. And then the worst part about it is one of the persons who was on the program came and spoke to our group and didn't know what the program was about. So just, check it out. Whoever's doing the evaluations, check it out. Now, I'm not going to tell you who it is because our CEO, we don't badmouth anybody, do we? So I just want to let you know. And that's from 36 years of dealing with them. Okay.
Thank you.
That's all I got, brother. This is my brother tonight.
Any other questions? I can't tell if there was a hand or a wave or, no, okay. Mr. Cowan, yeah. Well, you look like you were raising your hand and then you put it on your mouth, so you confused me.
Okay. All right. Change is never easy. I've been here long enough now, 5 years, that every time we've been criticized for making a change, we've done a pretty good job at it. Most recently was the whole transportation situation. And I was concerned about that because I thought, that's a big thing to take over, affects a lot of people. But it's worked out pretty well. It was a good transition. There was some, I think we only lost one vendor who went forward. And I know we've talked a lot about improving the crisis continuum of care that we're hoping to do now. And I think we're uniquely positioned now with some of the things that we've been doing, especially with the crisis training with the police departments, because they're the ones who see this first. They're the ones who report the crisis. They're the ones who have to deal with the crisis. Well, we're training them. We know them. They trust us. And I see today we got a nice note from the police chief from Madison Heights saying he fully supports this endeavor to handle adult crisis services. So that's nice. I'm sure if we went and got active about it, we'd probably get more, but we don't need to do that. We're about the service and providing the service. So I think we've had a track record of getting things done and improving the services, and this is just, I think, one more example. Yes, it is a significant one, but this, as we've discussed, this wasn't a decision that was made lightly. The people at Common Ground who have worked in this field are going to be given the first opportunity to work with OCHN. So we're not, throwing people out. We're hoping that they come along. And what it's really going to do is be a change in leadership of these services. At the end of the day, if a lot of those workers come on, plus the people that we have working together, the people are in the police departments that we work with on a regular basis, they're still going to be in place. So, and also that we have very good relationship with. What the goal is to improve the service, and I think you've laid that out of how you want to achieve that. And we just were able to go up at the conference and hear from, I think it was Wayne, Kent County, Genesee. There were 2 or 3 counties that it was very impressive that talked about what they do, and it is interesting when everything is under one umbrella like we will have, there is a lot more you can do to streamline, to improve the services. Because at the end of the day, these dollars that we have to stretch to serve as far as we can. And our organization is built on dealing with people in crisis. That's what we do, and to solve those crises. So we are the only network that does not, in the state, that does not provide crisis services directly. We do some, but not the main body of it. And so I think we're going to, this, plan has been put forth. It's a good plan, and we're never going to make everybody happy. We know that. Like everybody here knows my favorite line. If you wanted applause, you should have joined the circus, because we're never going to get applause, okay? But we have a satisfaction in knowing that we are providing services, we are improving services, and helping a lot of people, families, and people in crisis. And that's what this goal is. And I think we're uniquely suited to take on this task because of the track record we have, the relationships we already have. And the goal, number one, is to provide the services. I'm especially, I know one of the things that needs to be improved is, we've talked about this, is the intake time, direct response, which I think we can do a very, very good job at, and getting people where they need to be, and the families also who are adversely affected by whatever crisis is going on with their son, daughter, brother, sister, whoever it may be. So I want to applaud you for the plan you put forth. I know the details are all going to be, there's a lot of details to work out. I know the county, from their part, wanted to know where the service is still going to be in place on the campus, and the answer is yes. So we've had a good relationship. It's been a relationship with Common Ground over the years, and it's changing, and we're going to move forward with this plan. And as we've learned, most recently with this procurement process that the state's put in, nothing lasts forever. I'm not sure what the state is doing is going to improve things, but I am very convinced that what we're going to do here is going to improve the delivery of crisis services. And keep in mind, when the community needed, when Oxford happened, when Rochester Hills happened, it was OCHN who was in the front of that, coordinating all those services to get to those families and those communities. So I think, again, that's just another example of the kind of excellent work that we do. So just wanted to get that out.
Okay. Any other comments? Thank you for that inspiring presentation. I think Sarah, back to you, where we started.
I know.
It's like the batting order. We've gone through the order. Go.
Quick, I promise.
That's okay.
No, I just want to say this is, I think this conversation was helpful, and I think this is what the board is looking for. So I think, again, had we had this a little bit sooner, it would have been helpful, but just a learning curve, I suppose, or something that we can hopefully move forward, because even to the point of it was in the strategic plan and goals. I mean, we did see all of that, but it was not explicit to this extent. So having read the strategic plan and goals, I would have never equated that to this. And so I think that's where we need a little bit more communication. So I'm happy this happened tonight, and hopefully we'll move in that trajectory in the future with other big ticket items. So thank you.
Okay. Adam, any comments? Since I think we've gone around the horn.
Generally, I would echo what Sarah said in terms of clear, upfront communication about big things like this. And yeah, I look forward to that same procedure going forward. So great.
All right, thank you. Thanks for the really detailed, good presentation. So I think a couple takeaways I have is, it's been described different ways, but in terms of the transition, the intake, the access points, I mean, as we've talked kind of throughout everything that we do, people first engaging with this, whether it's a little crisis, an evolving crisis, or a full-blown, aren't always sure where to connect. So let's make sure we're ready on that front. And then as we get into maybe a study session down the road, we've got the macro level timeline, but I think getting a little more micro into it would be helpful. So, all right, thank you, ladies, for presentation and for your attention, and also just kind of like to thank the board for being not shy about commenting. I think it's a healthy discussion.
Thank you.
Yeah, all your pronouns rather than proper nouns. I think everybody's curious, Pastor Jones. Okay, item 4B, events and outreach. Suzanne.
Good evening, everyone. I'll be brief. As you can see, we're winding down the year, but we do still have some great community events and outreach that have been happening. Some things have already happened. We've had some trainings that have happened, as well as a community event. Just this last Saturday, we had a group home celebration here in the building, so I'll show you some pictures of that at the end. Also, we had an event yesterday, always supporting our Everybody versus Stigma and their foundation efforts. You mentioned e-community services. They actually have outgrown their space in the Pontiac area, so they're having another grand opening of their space, and Dana and I will be there for that event. Looking forward to it. Some other trainings Dana already mentioned. She's presenting to the Board of Commissioners this week. Next slide, please. We have our SUD workshop coming up this week on Thursday, so if you'd like to join, you can join. That's a virtual community workshop, as well as some training that we have coming up. We are hosting our all-provider meeting coming up this month, and then a couple of training, and then we have our Metro Region meeting coming up next month. Next slide, please. Press releases, already mentioned, our CIT International Platinum designation. Very proud of that. Have a picture to share with you at the end as well. As well as our Veterans Observance. We are going to be hosting a Veterans Community drive-through event. We hosted it last year, so this will be our second annual. Be hosting it in our parking lot here next month, so looking forward to that, as well as a press release for Family Caregivers Awareness Month. And then our continuous outreach and conference room usage. And then our final slide showcases our CIT training designation, picture of Dana, Sheriff Bouchard, and Trish, as well as a snapshot of the group home program that we held here last weekend. That's it for our community outreach for the month and upcoming month.
All right, thank you, Suzanne.
Thank you.
All right, second opportunity for public comment. Anybody online?
If you are online and wish to speak for public comment, please raise your hand at this time. Heather, you can go ahead and unmute.
Thank you for the opportunity. I've listened to the thoughtful discussion of the OCHN board tonight, and I know everyone's probably very tired, so I don't want to bring up all of the statements that were made that were inaccurate, because I think we're beyond that point from the OCHN administration. But instead, what I want to focus on is we received the transition plan on September 29th, and it has very, very tight timelines, like 2 weeks to transition each service, which I think is not a sign of a successful transition plan. And my overall statement about this transition plan is I think it has a low likelihood of success. I provided the reasons for that in my letter to OCHN, which I encourage you to request a copy of, because we outlined as common ground our issues pretty clearly. But with any goal of a seamless transition, you need to have two parties who are working together, and you can't have one party saying it's our way or the highway, and we are not going to negotiate. And you can't have the other party who is having to give up everything and transition their staff to unknown leaders to share our intellectual property and policies and procedures, and then to somehow indicate that our staff are the ones who need crisis training. I don't think there's going to be as many Common Ground staff who want to work for OCHN for a variety of reasons, and that's not good for anyone. We've got to have the Resource and Crisis Center adequately staffed for a transition of this magnitude. And it needs to be done in such a way that there is not one of the two parties that has 100% control and can just say, no, we're not going to do that. It's going to be our way. And so I want to bring that up to the group because I think this transition is so important to have be done right. And no offense to the attorneys in the room, but for it to be done right, I think we have to have no attorneys, Common Ground attorneys, OCHN attorneys, as part of trying to figure out how we're going to do this transition. It stops the conversation, and that's not what we need, and that's not what stakeholders in our community expect of any of us. And I will leave my comments there. Thank you for the opportunity to speak.
All right, thank you. Any other online? Anyone in the room? Yes. Yep. Probably better to come up. Yeah, yeah.
Hello, thank you for letting me speak. I apologize for being late. I was on a crisis call. I'm Pepper Catt. I'm a peer recovery coach. I work for the Alliance of Coalitions here in the OCHN building. And I've been with the Crisis Response Unit since April 1st of 2024. We are CIT trained peer coaches. Before that, I was a peer coach in Macomb County at McLaren Hospital for a year. And before that, I worked at Sacred Heart in Madison Heights, doing intakes and front office support there. I've been familiar with Common Ground and the Sober Support Unit really since I started working at Sacred Heart, which was 2020, so at least 5 years now. I'm a person in recovery, and I'm the mother of someone in recovery. And when I heard about what was happening, I wanted to be here tonight in support of OCHN. I think a lot of times we get so caught up in not bad-mouthing our partners that it turns into protecting things that don't need to be protected. As a peer coach and an advocate, I really want to hold everyone up to the same standard that I hold myself up to. I don't think it's about bad-mouthing our partners. I think it's about showing light where light needs to be shined, because there's definitely many instances that make me afraid to send someone in active addiction to Common Ground by themselves. I've had numerous bad experiences in the lobby. I've had participants I've worked with tell me they've been told to leave, that they can't get help there. My own daughter was told that she was numerously flushing a toilet when she couldn't drop because she was dehydrated at 3 o'clock in the morning while she was trying to get herself help from an opiate addiction. I've had people sit in the lobby for 6 to 8 hours. I've had people waiting to be turned away because they didn't have the proper medication. I've walked into the lobby with the deputies I work with and had people behind the counter roll their eyes at me. I've seen people behind their counter yell at the deputies I work with. We're making a statement, official statement with dates to submit for anyone that wants to see that, so it's not just hearsay. These are things that have happened over and over and over. If I know someone is struggling and wants treatment on the weekend, I'm afraid to send them to Common Ground because I'm afraid what kind of service they're going to be met with when they walk through the door, depending on how they may present, if they're angry, what kind of crisis they're in. when people are in crisis, they can't walk up to a counter and say, please help me. A lot of these people have been homeless, unhoused, they've been through serious trauma that most people can't even imagine going through. People are going to be upset when they go in there, and I have not seen person-centered care. It really breaks my heart, and I do know that we as a company, the Alliance of Coalitions, had meetings with the staff at Common Ground trying to address some of these things, hoping that they would be changed and it wouldn't have to escalate. And these things never changed. So I'm looking forward to OCHN being more involved there. I think that it would actually have a very high level of success considering all the trainings that they do, all the trainings that they put out, the co-responders that they have, the CIT. So I just wanted to voice my experience with Common Ground, and thank you.
Thank you. Any other? Okay, we'll shift gears to board member comment. Go first. Christina passes.
Great meeting, great board, great discussion. You know, I tell you, every time I come, I'm excited and more information and what have you, and all of that. And I to all my board members, I just appreciate all of you. Listen, everywhere I go, I speak proudly of OCHN. Talk about it, what they do, the job they do, the people they serve, and all of that. And you've heard me numerous times say that I appreciate the employees that's here. I think you guys do a great, guys and girls, do a great job. You know, if I call you for something, you really are responsive. I got a number of people that just talk about you all a lot because of what you do. Trina, really appreciate what you do. One of the biggest things that I think we need to do more, toot our own horn. You need to toot your own horn. I keep talking about, hey, talk about what you do because you do a great job. We have great leaders. I appreciate them, you know, whether you're head of a department, whether you're a program manager or what have you, a lot of great leaders, a lot of people that's really engaged. And I really appreciate that. And that goes well and fares well within the communities and all of them. Who went to Oxford? OCHN. Who went to Rochester? Crises? OCHN. Pontiac? OCHN. I mean, name the city. You name the city. Name the school that the employees and the people of OCHN went there. Not just on a Monday through Friday, but what about the Saturdays? And, you know, I call you on a Sunday, you know, because that's my work day. It's my work day. So the thing is, you all do a great job, and you got to start tooting your horn more. And, you know, people can say whatever they want to. Other groups do it. But you do a great job. The event, you know, Suzanne, I don't know how you do it. The number of events, always there. Those things happen, and you guys are there. And so, you know, people may not know. They may not know the number of people that you help. We do the stories, Happy Mondays, whatever it's called. It's not Happy Hour, is it? I don't want to get the wrong thing. But what happens is people come and talk about what you did for them. And that's important. That's important. And so we're going to run into these crises. We're going to run into them. There's almost not a group that I haven't had over the 36 years to work with, deal with, and work with. I've worked with Common Ground. And change means more expectation. Those that are watching and all of that, you know, hey, we do a great job. And I like what our chairman said. I've said it so many times. He says, we do and try to serve as many as we can with what we have. And that's a great statement. And it's a great policy, and it's a great actuality. We always don't have all of it, but he does a great thing. So that's important. So, you know, I don't know how many minutes I got, and I didn't bring my sermon notes, but the most important thing is, you know, toot your own horn, because you're doing a great job, and people need to understand that. Thank you for this time.
Adam.
I'm not going to follow that.
Notice how I did that, right?
Yep.
Yeah.
Appreciate it.
All right. Sarah?
No comment.
Chris?
Just to the recap on the Richard Carpenter conversation, it reminded me of a presentation I gave last week in which somebody asked, is like, how do I know what Medicaid I'm on, particularly on the IDD side, what waiver I'm on? Like, if there's any way we can start communicating that more upfront, like upfront on the IPOS or wherever it is, so people start knowing that, because I think what bucket people are in, as Mr. Young would say, is going to be more and more important as cuts come down, and the more we can educate providers and so forth on how to respond and get people in the right buckets. You have more faith in DHHS workers than I do, Dana. But, you know, if we can educate providers on that, that'd be great. And just briefly, I don't want to rehash, but, like, you know, those who know me, like, I'm extremely loyal. I want to be as big of a cheerleader as Pastor Jones and Pastor Mr. Cowan. Like, that's who I am. That's my nature. But I'm not there yet. And to get there, I've got to have data. I've got to have information. I mean, we're showing up 3 times a month to these meetings, and giving the time to do that. We've got email addresses and so forth. And I still can't articulate why we're taking this away from Common Ground specifically. And I don't think that's right. You know, Nassar gives us a contract of a $100,000 IT contract, and we have to take a roll call vote on that. But, you know, here we're cutting potentially $14.8 million from a Common Ground provider, one of our top 5 providers, and I've never taken a vote. And I'm willing to make those hard decisions. Like, bring those decisions to us. Bring us along with it. I understand we're not supposed to get in your way, but we can also be your greatest cheerleaders. When you go to the Board of Commissioners, I don't think you can say on Thursday, the Board of Commissioners, or you have the support of the OCHN board, because I get it, it's buried in some annual plan, but we've never had that specific question of whether we want to take the contract away from Common Ground. And I just don't think, as people appointed from the Board of Commissioners, as people representing this community, like, we're here to make those hard decisions. Let us make that hard decisions. Give us the data to make those hard decisions. Thank you.
Dr. Hans?
No comment.
Okay.
I appreciate all of the discussion tonight on the various subjects that we have discussed. I have 20 years experience in Oakland County working with providers. I've interfaced with Common Ground on many clients' behalf during those 20 years. I've also have 20 years experience working in Wayne County. I've had experience in Genesee County. So I am aware that change does take place, and sometimes we may not be ready for it. I know when the mobile crisis units first came out, people were very upset that they weren't going to go to a facility, that people were going to come to them, or telehealth. Change is hard, but sometimes change is necessary. Thank you.
So I'd just like to thank the board members. This was a healthy discussion. There's different follow-up pieces for the full board meeting. So we'll see everybody next Tuesday. We stand adjourned.